Fine. So we'll start with multiple sclerosis today. So the investigations of multiple sclerosis are, first we'll do a evoked potential. So what is an evoked potential? An evoked potential is done to check the electrical activity of certain area of brain or the spinal cord, right? So the electrical activity we can see for a multiple sclerosis, right? Fine. Then the most important thing in the investigation is the CSF. So we'll take the CSF of the patient, then we will assess the immunoglobulin G level in the patient. So which will be increased, right? So the immunoglobulin G level will be increased. Other than that, there will be increased rate of synthesis of immunoglobulin G. So that is increased rate of synthesis of immunoglobulin G itself, right? Fine. Then after this, we'll also see the mononuclear pleocytosis. Mononuclear pleocytosis. That is, there is increased amount of or increased number of mononuclear cells in the CSF, right? So after this, in the CSF itself, there is one more important thing that is elevated. What is it? It is increased oligoclonal bands. What is it? Oligoclonal bands, which will be increased, right? So these are the main investigations that we actually do. Other than that, we would also do an MRI, right? So in the MRI, we'll use a gadolinium enhanced MRI. What is it? Gadolinium enhanced MRI. Fine. So in here, I have only kept the some important points about the multiple sclerosis, and I am not explaining you everything about multiple sclerosis. In that, we have to know the treatment for acute exacerbation of a multiple sclerosis patient. So for that, we would actually give the methylprednisolone. What is it? Methylprednisolone. Fine. So this is a one-liner question. That is, during the acute exacerbation of multiple sclerosis, we'll use the methylprednisolone. Right? Fine. After this, there is something called as Dawson's fingers. So these are certain things that makes the multiple sclerosis more interesting. It makes reading this multiple sclerosis more interesting, right? So what is Dawson's finger? So the Dawson's finger is the demyelinating plaques which are seen in the brain. See, this is a flare image, flare sequence of MRI. What is it? Flare sequence of MRI image. So this one, right? In here we see the demyelinating plaques are seen in these regions, right? This looks like a finger, right? These are the Dawson's fingers, right? So these will be perpendicular to the lateral ventricle, right? Perpendicular. See, this one is one plane, and perpendicular to that we'll be having this Dawson's fingers, that is demyelinating plaque. So this is the whole of this lateral ventricle, right? So this is the lateral ventricle. In that, it is these fingers are perpendicularly located and they are radially extending from the lateral ventricle, right? So that is happening. Then we would also have these things parallel to the medullary veins, right? We'll be having these veins around here, right? So it is also known as perivenular inflammation because all these veins will be going around here. So which will be, so these demyelinating plaques will be parallel to the medullary veins, right? So that is a good finding in the multiple sclerosis. Fine. Then we will see about the dosage of the glucocorticoids that we use in the multiple sclerosis, right? So first we will use the IV methylprednisolone, right? Fine. So IV methylprednisolone will be given at the rate of 500 to 1000 milligram per day, right? So which will be given for 3 to 5 days. How many days? 3 to 5 days. Then what we do is we'll start the patient on oral prednisolone. What is it? Oral prednisolone. So for oral prednisolone, it will be around 60 to 80 milligram per day, right? So this has to be tapered. What is tapering? That we decrease the dosage of the drug over 2 weeks. That is the tapering of dosage will be done by 2 weeks, right? So this is the important thing about the dosage of glucocorticoids in the multiple sclerosis. After that, we would also have an important point here. In this, what is not a bad prognosis for MS? They will ask you, what is not a bad prognosis for multiple sclerosis? We may actually get confused here, right? Sometimes the patient will be presenting to us with optic neuritis. What is it? Optic neuritis. So we would obviously think that it is a bad prognosis, but it is not. So when the patient is presenting to us with optic neuritis, it is actually a good prognosis. Why? There is a reason behind this. Why? Because in the optic neuritis, we can give the patient steroids, and the patient will be very well responding to the steroids. This optic neuritis will be having good response to the steroids, right? That is why in optic neuritis we'll be having good prognosis for multiple sclerosis, right? Fine. Thank you.